All right. Moving on to the next genus, we're going to talk now about strep. We mentioned strep a little bit earlier, and I told you that strep are catalase negative. And as you can see in the image here, unlike staph, which are typically present in grape-like clusters, strep is present in chains, all right, more often than not. Now, can you differentiate definitively staph and strep based on their gram reaction, being grape-like clusters versus chains? No, you cannot, all right? I've seen many a gram stain of strep where it's so thick you wouldn't be able to differentiate it from staph. You still have to go with the catalase test. They'll always have that in the distractor list because they'll trick you by saying, what's the simplest way to differentiate between the most likely causative agent? And they'll have catalase, which is the right answer. They'll have coagulase, because it starts with a C, and you may get confused. And they'll have gram stain, staph in clusters, strep in chains. All right, don't ever pick that, because that's never enough to differentiate between those two. Okay? They're also grouped, as we mentioned, by the carbohydrates in the cell wall. That's how we get group A strep, group B strep, group D strep, etc. They can also be serotyped by the capsule, as can be with strep pneumo. Additionally, they can be serotyped by way of their M protein. And the best example there is strep pyogenes, and I'll talk about those again once we get to the specific organisms. Each one of these species are really considered high yield for the board. So group A strep, extremely important. Group B strep, being the leading cause of neonatal meningitis, very likely to show up. Streptococcus pneumoniae, leading cause of lots of stuff, yeah, probably going to show up. Viridans strep may not show up as a primary question, but you know you'll see it in the distractors, okay? And then, of course, Enterococcus. That one may or may not show up, but the top three are really extremely important. So we're going to first look at the group A strep, all right? Group A strep, we mentioned earlier, are beta hemolytic. So what's that going to do is going to clear the blood on that blood agar plate, all right? It is sensitive to bacitracin. That's how you're going to differentiate it from group B strep, because remember, group A and group B are both beta hemolytic on blood agar. Okay, PYR positive, okay, group A strep, and I mentioned the enterococci are PYR positive, just an enzymatic test that can help you differentiate between group A and some of the other different types of strep. Now, where does group A strep reside? Typically the throat, and can be transiently on the skin. Therefore, transmission is typically by respiratory droplets and coughing or direct contact, as we talked about for Staph aureus. Pathogenesis, again, you look at the virulence factors for strep pyogenes and you're like, man, there's a ton of stuff there. Agreed, there's a ton of stuff. Not everything you have to memorize though, all right? It has an M protein, and that functions in an anti-phagocytic manner. That being said, as far as immune evasion, is going to be an extremely important virulence factor. Additionally, certain serotypes of M protein are more often associated with causing post-streptococcal glomerulonephritis. So again, the M protein shows up, all right? Streptolysin and the O and the S types probably not likely to show up, except for maybe in rheumatic fever, and I'll talk about that. Now look at the spreading factors. What did I say earlier about the difference between staph and strep? In staph, you're going to get a localized infection, and strep is going to tend to spread. So these basically list all the spreading factors for group A strep. Do you have to know every single specifics about it? Absolutely not. But look at the overall theme of what's going on here. You have streptokinase, it's breaking down fibrin. You have a DNase, liquefying pus. You have hyaluronidase. These are all allowing that infection to spread very easily. Now, the exotoxins are also, I'm going to say, relatively important for two reasons. Number one, they function as a superantigen, very similar to toxic shock syndrome toxin. And number two, they cause the fever and the rash that you see with scarlet fever. Okay? So, you get a patient, you have a child that presents with a sandpaper-like rash, so it's kind of rough to the touch. They may have desquamation on the palms and soles, very red in the groin area. They clearly have fever, they may have vomiting, and they may probably be some history of pharyngitis, although they won't probably mention that it was strep throat. So, then they might say, given that vignette, what is responsible for the rash in the above vignette or in the above case? And it's the exotoxin, okay? It's the streptococcal exotoxin. So that's the clinical relevance of those exotoxins. That's how they're going to work it in to that vignette and ask you about those virulence factors. All right, now the diseases for group A strep infections, clearly everyone's familiar with strep throat. We've probably all had it. We know that we'll get those nice little pus pockets in the back of our throat. Very, very sore. Feels like somebody smacked you with a meat cleaver back there. It's just raw, raw, raw. Are they going to ask you just a flat-out question about group A strep throat? No, it's too easy. What are they going to say? Somebody had a strep throat and we found beta hemolytic? No, they're not going to do it. But what they're going to do is ask you some of the sequela, or they're going to ask you about scarlet fever, okay? So they're going to mention that the child, before they started getting all edematous and gray looking, had a strep infection, a recent strep infection. So you're supposed to make the connection between glomerulonephritis and the pharyngitis, okay? So while I don't think it's very likely for you to get a straight first order question on group A strep pharyngitis, it will be an indication for some of the diseases we're about to talk about. Scarlet fever, absolutely. Okay, scarlet fever is still one of the board favorites. We still see scarlet fever. In fact, my son recently had scarlet fever. He's the kid that never complains about everything, so we didn't even know he had a sore throat. And all of a sudden, he gets this bumpy rash all over his body. Okay? Still never complained about a sore throat. If he had a fever, it was fairly low grade. And then he started getting desquamation on the palms and soles. So, of course, Mom, being a microbiologist, I had a rapid strep test at work, took it home, bam, he was positive for strep, and we took him to the pediatrician so he could get treated for that. We treated him for that because we didn't want him to get some of the sequelae like acute glomerulonephritis or rheumatic fever, okay? So what are the signs of scarlet fever, the sandpaper rash? What does that mean? It means that your skin feels like sandpaper. Palms and soles are usually spared, meaning they're not usually affected by the rash, but you can definitely get desquamation, all right, and that's actually fairly common. Strawberry tongue. Your tongue has all kinds of bumps and is very, very red. It actually looks like a strawberry. Very common. My son didn't have that either. Nausea, vomiting. All kids have that, and that's, we know, a lot of fun. So scarlet fever, absolutely. Definitely, I would put as a high yield question. Impetigo, honey-crusted lesions, absolutely. And just as we talked about, you'll have to differentiate that between staph and strep. Now, cellulitis, necrotizing fasciitis, all skin diseases from group A strep. Now, here's my next little friend. This is the flesh-eating bacteria. Now, hopefully you can see this. First of all, it's strep. So we know it's a cocci in chains, basically. But if you can see this, I'll try to put it up there. You can see he's got a knife and a fork. So he's a flesh-eating bacteria, all right? So remember that. What does that mean? Basically, all of those spreading factors we talked about are going to allow the organism to spread through the skin. Necrotizing fasciitis is very fast acting. Typically will require amputation, and if you don't catch it fast enough, has a very high fatality rate. All right. Here's an image of group A strep. You know you're going to see an image on the boards, lots of them, but this is just an example of what you might see with group A strep. So you definitely see those pus pockets from the bacteria in the back of the throat there, very common for group A strep. Do I think they're going to show you that and ask you what it is? I don't, because it's too simple. Here's an example of scarlet fever. You can't touch this kid and feel that his skin feels like sandpaper, but that's what his skin would feel like. You can see in the groin area it's much more red than it is around the rest of his body. That's very common for scarlet fever. And here's an example of the strawberry tongue. So you can see how erythematous it is, and you can actually kind of see that lumpy, bumpy appearance on the tongue there. That's what we mean when we say strawberry tongue. Now, what is really high yield for group A strep infections are the sequelae to those infections. And we mentioned them earlier. We mentioned rheumatic fever, and we mentioned post-streptococcal glomerulonephritis when we were talking about damage done by the immune system. Okay? So, what they're likely to say is, again, you had maybe you had a child that had streptococcal pharyngitis. You gave them the antibiotics. They started taking them and they felt better, so they stopped. Very common. So they stopped taking their antibiotics, and then a few weeks later, they start to develop the fever, the joint inflammation, and the carditis. So they may have a murmur. And you have to be able to link that with the type 2 hypersensitivity. All right? So here's the way they're going to ask you that. They're going to give you that vignette. They'll present the symptoms with a history of pharyngitis. Okay? They will want to know what type of hypersensitivity it is. Sometimes they get even pickier. Okay? And sometimes they want to know what is the mechanism of the hypersensitivity reaction in the above case. In this case, it's type 2, we already said, so the mechanism are antibodies binding directly to cells or tissues. All right, in the bottom, we have post-streptococcal glomerulonephritis. And we mentioned earlier again that this was a type 3 hypersensitivity. Again, you'll have the history maybe of the pharyngitis. You'll have this kid who's all puffy. He's hypertensive. He's got this dark kind of colored urine. The parents are panicked. They have no idea what it is. And they'll ask you either A, what type of hypersensitivity it is, and you know it's type 3, or they'll ask you the mechanism of that hypersensitivity. And remember, anytime we're talking type 3, we're talking these circulating immune complexes, okay? So this one, you definitely got a star. You know one of these is showing up, okay? So that's extremely high yield. Lab diagnosis, most of us know that for diagnosis of strep, we can do a rapid strep test. Now, are they going to tell you that on the boards? Are they going to say, this kid came in with a sore throat and we did a rapid strep test and it was positive, what is it? No, they're not going to do that. You wish they would, but they're not going to do it. What they're going to do is they're going to say, we cultured it on blood agar, it was beta hemolytic, okay? So that's how they're going to tell you about the diagnosis. I said we'd talk a little bit about streptolysin O, and the reason is because it can be used in the diagnosis of rheumatic fever, where you have antibodies to streptolysin O at a titer of greater than 1 in 200. That's going to be significant for rheumatic fever, okay? Now, treatment is really actually very simple for group A strep. We're still, first line of therapy, going to go with the beta-lactam. So we're going with penicillin. Okay, that's your first drug of choice. In cases of allergies, we're going to go probably with the macrolide. Prevention, in the case of someone with rheumatic fever, you're going to use prophylactic antibiotics. Okay, because if that person gets another strep infection, that rheumatic fever can be much, much worse the second time around with that memory response. Okay, so those are the treatments for the group A strep. All right, so we're going to shift from Group A to Group B. Not a whole lot to talk about with Group B strep, okay? What do you already know? It's a leading cause of neonatal meningitis. Bam! That's almost everything you got to know, okay? Distinguishing features, we mentioned most of them. However, you can see down here that it's CAMP test positive. CAMP does not mean cyclic AMP, okay? The CAMP is a factor that is secreted from Group B strep that enhances the beta hemolysis from Staph aureus, for example. So if you cultured Staph aureus and Group B strep, the CAMP factor enhances the beta hemolysis, and what will happen is you'll get what's known as an arrowhead formation. That's what CAMP factor is. So don't confuse it with cyclic AMP, because that's not even close to what it is. Reservoir, it's normal flora in the vaginal mucosa, 50 to 20% of women. And that's clearly how you know now that it's a leading cause of neonatal meningitis. So it's transmitted typically during birth, usually from either the vaginal flora, the fecal flora. So women now that get routine prenatal care are tested for Group B strep during the pregnancy. Now, what are we going to do? We find out that you have a pregnant patient who's Group B strep positive. Are you going to treat her right then? The answer is no, because if the Group B strep is part of her normal flora, by the time she delivers, you're basically going to have to check her again anyways, and probably going to have to treat her again. So if you find that your patient is Group B strep positive, you treat her with antibiotics at delivery, okay? So the disease, neonatal meningitis, most common cause. You have to know that. Now, I gave you a scenario earlier of neonatal meningitis when I said gram-positive cocci found in the CSF, maybe gram-negative rods found in the CSF. With things that are the most common cause, they can simply do this. They can say, you got a neonate with meningitis, well, what's the most likely cause? Okay, but they'll give you a vignette. So you really have to have in your mind a good idea of what the most common cause is. Treatment with Group B strep is ampicillin with an aminoglycoside or a cephalosporin. Honestly, for meningitis, any of the meningitis questions, is always safer to go with a cephalosporin, okay? And prevention is what I was talking about earlier. Prophylaxis is that we treat her. If she's Group B strep positive, we're going to treat the mother during delivery, all right? Next on our tour through the streptococci, we're going to talk about Streptococcus pneumoniae. Again, this is a really high-yield organism because as far as most common causative agents, it is way up there for a lot of the different diseases. Now, as we talked about earlier, strep pneumo is alpha hemolytic. Now, we didn't actually talk about what that was. Alpha hemolysis is when the organism partially lyses the blood on the blood agar plate. And instead of getting clearing around the blood, it actually turns a little bit green. So they'll say a greenish color for alpha hemolysis. If you look at the sputum gram stain shown in this image, you can see that typically strep appear as diplococci. So in several examples, you can see that they're 2 by 2 by 2. And if you'll really pay attention, you'll see the gram-positive organisms, the dark purple organisms, and you'll see almost like a halo surrounding the organisms. What is that halo? That halo is the capsule, okay? So you'll remember that the most important virulence factor for Streptococcus pneumoniae is the capsule, right? Now, strep pneumo can be normal flora in the upper respiratory tract, and what you're going to see with strep pneumo that you'll see with a lot of other diseases is that a lot of people can carry this as part of their normal flora, and some people will get terribly sick with strep pneumo and others will be fine. And that tends to be more of a host issue, but as far as precisely why that is, I don't think anybody's actually pinpointed that yet. So transmitted, because it's part of the respiratory tract, by respiratory droplets. What are some of the predisposing factors for Streptococcus pneumoniae? Like we talked about with Staph aureus, you can have a viral infection in there that beats up the respiratory tract, allows other agents to get in there a little bit easier. Asplenia is a big one, okay? Predisposes individuals to sepsis. And what you'll find is that in somebody with asplenia, functional, okay, it could be sickle cell, for example, they will tend to get septic from organisms that are encapsulated, right? So it's not just going to be with Streptococcus pneumoniae, but that happens to be one of the predisposing factors. Now, alcoholism, I know when you think pneumonia and you think alcoholism, you think Klebsiella pneumoniae, all right? But strep pneumo is still the most common cause of community-acquired pneumonia, even in an alcoholic, all right? So you're really going to have to pay attention to the question if they're talking about an alcoholic with symptoms of pneumonia. Pathogenesis, the only thing you really need to pay attention to as far as the virulence for strep pneumo is going to be the capsule, as we mentioned earlier. Now, the diseases, here's where you can clearly see why strep pneumo is a very high-yield organism for step 1, all right? Community-acquired pneumonia, it's the most common cause, all right? Patient presents with fever, shaking chills, rust-colored is the buzzword, i.e. bloody sputum, okay? Now, in cases of strep pneumo, Klebsiella, they may describe for you the chest x-ray. They're going to say it's consolidated. It's lobar consolidation. And that's going to be different than some of the other types of pneumonia that we're going to talk about, all right? So, most common cause. Adult meningitis, strep pneumo, most common cause, okay? Otitis media and sinusitis in kids, bam, most common cause, all right? So you have most common cause of community-acquired pneumonia, adult meningitis, and otitis media and sinusitis in kids, okay? That's what makes it a very important organism. So you know you're clearly going to see a question on strep pneumo on step 1, all right? Now, diagnosis. This one cracks me up. Quelling reaction. Quelling reaction is not specific for strep pneumo, but more an organism that has a capsule. Well, they'll add antibodies specific for the capsule, and you'll get swelling of the capsule. Now, do we use that much anymore? No. But when you got Grandma writing the questions for the USMLE, she's going to remember the quelling reaction. And that's all she's going to remember. She doesn't know nothing about no latex particle agglutination. So, do we use it? No. Do you have to know it? Yes, you do. Because they'll say quelling positive. Now, unfortunately, Grandma writes more than just this question on the board. So you're going to see tests that we don't use anymore showing up on the boards, okay? So when we're going through this stuff, you're like, we don't even use that anymore. Clearly, we don't use it. We have better, faster, more specific tests, but old schoolers, they're still going to want to know you know what that is. So quelling positive usually is to describe an encapsulated organism. Now, that's been mostly replaced by what you see next, which is the latex particle agglutination. And that tests very specifically for the capsules in the CSF. So either one of those you should really have a handle on for diagnosis. Now, along the lines for treatment, it's going to differ. Whereas in pneumonia, your DOC may be a macrolide. When you get to meningitis, remember I said you always be safe with a cephalosporin for meningitis, okay? So ceftriaxone is a good choice for meningitis. And then again, otitis media and sinusitis, typically you'll start with a beta-lactam, but there is actually a lot of resistance developing in strep pneumo, so you may have to move up the ladder for that, going to a macrolide, for example, for treatment. Now, prevention for strep pneumo is that we have a vaccine, a couple of different types of vaccines actually for prevention of strep pneumo. Now, here's a good time for me to talk about vaccines a little bit. Every time we get to a bacteria that has a vaccine that can help protect from that bacteria, you have to know it, okay? So what do you have to know about it? You have to know that we have vaccines for strep pneumo. You have to know when we use it, and you have to know what kind of vaccine it is, because they're going to give you a scenario, inevitably, of a patient that's either pregnant or has HIV, and they're going to want to know which vaccines are safe. And if you don't know what kind is which, you're never going to know which kinds are safe to give, okay? So polysaccharide vaccines are safe to give for immune-compromised and pregnant patients, and that's what the strep pneumo vaccine is. There are actually two different types of vaccines here. We have the pediatric vaccine versus the adult vaccine. So the strep pneumo vaccine is actually one of the recommended vaccines that we give to all children that get routine pediatric care in the U.S., and it covers 7 of the most common serotypes. Now, I just told you strep pneumo is still the most common cause of otitis media and sinusitis. So you're probably like, well, the vaccine doesn't work. It does work. And the reason that we vaccinate children for strep pneumo is those 7 serotypes are the ones that are most prone to invasion. So most prone to causing meningitis, most prone to causing pneumonia. So in the pediatric case, we're just trying to prevent serious disease from Streptococcus pneumoniae, okay? The adult version of the Streptococcus pneumoniae vaccine, let's look at the difference. Here we have a pediatric case where their immune system's still trying to develop. We don't want to totally clear them. We don't want to vaccinate them with everything so their immune system doesn't have a chance to develop. Well, now you're looking at an adult, typically 65 years and older, immune system on the downward slide, okay? And it's perfectly okay to vaccinate, in this case, with 23 of the most common serotypes. Now, you're not talking about just the 7 most common serotypes associated with invasion. You got to go more broad, okay? So here, we give this to elderly adults over 65 and anyone with an underlying lung problem, COPD, maybe congestive heart failure, for example, might be examples where we might give that. Also, somebody that's lost a spleen would also be on that at-risk category for the Streptococcus pneumoniae vaccine. So, alpha hemolytic, gram-positive cocci, strep pneumo, next on the list, the viridans strep. I said it was important to know they were both alpha hemolytic. How are you going to differentiate them? You're going to differentiate them based on antibiotic sensitivity. And really we're talking about optogen. So the viridans strep are resistant to optogen, whereas pneumoniae is sensitive. We talked about the reservoir for the viridans strep when we talked about normal flora. So they're common residents of the oropharynx. They are typically associated with cavities, but can also be associated with endocarditis. They can find their way to damaged heart valves. And therefore, because we're typically getting them from our own flora, like we mentioned earlier, the transmission we would refer to as endogenous. Now, disease, we mentioned dental caries, very common cause of dental caries or cavities. And they may not say, hey, viridans strep, but they might list the species. So some of the species you should be aware that are in that group are Streptococcus sanguis and Streptococcus mutans, okay? Those are some of the common viridans strep. Now, subacute endocarditis, we also mentioned, so that let's say you have dental work and you didn't get prophylaxed, you have a damaged heart valve, you can dislodge some of those organisms, they can find their way to the damaged heart valve and they can cause endocarditis, okay? So it's something you're going to think about when they're talking about somebody that had dental work, they didn't prophylax for that, and they developed endocarditis. Probably, though, not the most common. We know Staph aureus is way up there, and we've already kind of talked about that. Treatment for the endocarditis, a penicillin with an aminoglycoside typically gives you good coverage. And as far as prevention, we're talking about prophylaxing when you have invasive dental work done. So if those organisms get dislodged from their normal resting place in your mouth, they won't find their way somewhere else in your body to cause infection.